get started, if that's okay with you, Noelle. Okay, well, I think we'll get started. So we are sure to give Noelle as much time as we can to speak. I'm really happy to see folks signing on, and I hope we get even more. Noelle, I had not met you. I have not met you before, and I had not known of you until I learned about your work with LGBT, the community and palliative care. So I have the honor to introduce Noelle, and we had a very long and impressive bio, but she has requested that we shorten that a bit. So here goes. Noelle Marie is an associate professor of medicine at the Icahn School of Medicine at Mount Sinai, Brookdale Department of Geriatrics and Palliative Care in New York City. She's a clinician and educator whose academic interests include pain management, rehabilitation and palliative care, LGBTQ holistic medicine, pediatric palliative care, and wound care, among many other interests, I'm sure. And a fun fact about Noelle is that she enjoys singing opera. And I don't know if we can entice her to give us a sample in this venue, but I would love to hear her sing sometime. So again, welcome everyone. And Noelle, the stage is yours.
Thank you so much, Tanda, for that lovely introduction. And yes, at some point, I'll be more than happy to sing. I really appreciate it. It's such a thrill and honor to be invited. Tanda, Pat, Bridget, and Kadra, thank you so much for extending an invitation to CIPC Center for Improving Palliative Care for Vulnerable Adults with Multiple Chronic Conditions with, Columbia School of Nursing. I am really delighted to present a topic that is very near and dear to my heart, that I'm very passionate about and such an advocate for. And what I really wanted to provide for the next 15 minutes is really talk about inclusive and affirming geriatric and palliative care for the LGBTQ plus community. You may call me Noelle Marie. My pronouns are she, her, hers. And if I can just invite everyone to also rename your names on your Zooms and add your pronouns, that would be great. Or if you don't want, you can just type in the chat box, and that would be great. If you have any questions or comments, feel free to type in the chat box, and we'll be able to curate the questions and answer them towards the end, just so that I'll have the space to be able to go through my presentation. I don't have any financial disclosures. And really over the next 50 minutes, I just want to touch on really three main themes. One is some epidemiologic landscape and perhaps some healthcare disparities affecting the adult and older adult LGBTQ plus population. There's much more data, and I'm just going to share with you some of the salient points. And then the second theme is really talk about guiding principles in our approach for the LGBTQ plus population. And then finally, I'd like to provide practical, inclusive, and affirming communication and clinical care strategies for those of you who are practicing clinicians and seeing patients at the bedside. I think that hopefully these tidbits will be helpful in your practice. So I'm going to start with a poll, and unfortunately I have to stop share here, and we'll just have to reshare, but using the poll. Give me 1 second. Share screen. So if you can, so this is the poll. The first question is, and just give me a thumbs up if you're able to view. Okay, wonderful. So the first poll question is, in the 2021 Gallup Poll, what proportion of the US population identified as LGBTQ+? So you can text 22333 to Noelle Marie J 447, and we can certainly see what the responses are. I'll give you about a minute to do that. So I'm seeing really a variety of numbers, 10%, 4%, there's one, 7%, 12%. Okay, sounds good. Don't hesitate to choose any of the options. There's no, no judgment in this safe space. So, okay, great. Thanks a lot. So I'm going to stop share and I'm going to share screen again. And this one, I'm going to go back to my presentation. So the Gallup Poll is really a think tank poll that really focuses on, it's a form of a national survey that really looks at different disparate populations and, just the population as a whole. And in this particular one, we're talking about the LGBTQ plus community, and they've really started to own up on getting some data around demographics around this population since 2012. And you can see that when it first started out in 2012, it was only about 3.5% of individuals, of Americans identified as LGBTQ. And then over the next 5 years or so, you can see a steady increment in terms of an increase in the proportion of individuals identifying. So from 3.5, there was a jump by 1%, in 5 years to 4.5%. I mean, we still feel that this is underestimated because not everyone was certainly part of the respondent survey, and we are also not sure, in fact, if people are comfortable even sharing this, disclosing their sexual orientation and gender identity. And then there was a lull in the 2 years of 2018 and 19. Unfortunately, owing to the previous administration's rollback of SOGI in these types of questionnaires, and every survey kind of followed suit. But thankfully, in 2020 and in 2021, we saw an uptick. So in 2021, over 12,000 respondents using telephone and online surveys, they were able to project that about 7.1% of the 336 million Americans in 2021 identify as LGBTQ. Majority, obviously it's only 7.1%, so majority still identify as straight or heterosexual. And within the LGBTQ cohort, it turns out that the bisexual population or subcohort is actually much more predominant. So this is the second question, second poll. I'm going to stop share and I'm going to reshare, share my screen, and we are going to go back to the next question. So I'm going to activate this. You guys can feel free. What is the estimated number of transgender identified individuals in the 2016 Gallup poll? And as you're keying your responses, the reason why I chose the 2016 was this was the most number of respondents. It was over 50,000, and it gave us a little bit of a flavor, a snapshot about the proportion of trans-identified individuals. So about 60% of you guys chose more than a million, and then split between about a million, and data is just not enough to share. Okay, great. Thanks so much. That is the last of my poll questions, just for audience participation. So in the 2016 data, 2016 to 2017, you saw that in the graph that it was 4.5% of the population identified as LGBTQ, and about 11 million, this is translated to about 11 million individuals. I certainly highlighted, because we're talking about disparities, and that obviously includes race and ethnicity as well, that about 40% were considered non-white. But in terms of the transgender population, more than 1 million actually identified, but close to about 1.4 million. So it's one in about every 200 Americans identified as transgender. Now, in 2016, the National Institute on Minority Health and Health Disparities identified LGBTQ community, also known as SGM, or sexual and gender minorities, as a designated health disparity population. And this is, for those of you guys who are in research, this is what exactly this slide is about, is around the research, around research data that we have, that even in this field, that we consider this population as, in fact, a health disparity population. Now, I wanted to humanize my talk by honoring and paying homage to a good friend of mine who unfortunately lost his life to cancer he was living with serious illness, but I really learned a lot from him. His name is Jay Callio, and he's such an advocate for LGBTQ rights. And I think that he completely embodied, the two fields that I'm practicing in, which is both in geriatrics and in palliative medicine. And, he really illuminated the different disparities and the different barriers to getting, high quality care, medical care, high quality palliative care, let alone, medical care. And he really focused on the fact that there is ongoing invisibility of the population, that there are structural barriers that are implicated, financial constraints owing to the lack of employment. There are known gaps in provider education and training. There's also a long history of stigma and oppression that really has defined this population and really put them on the map. However, I also don't just want to focus on the negative milestones, because there's also been a lot of positive strides within the LGBTQ plus community. And also, I wanted to highlight that, research and administrative policies are still, lacking, and that these are still areas that we can definitely continue to, to hone in. We also can hear that, even in our geopolitical climate, there's a lot of polarization around LGBTQ rights. Now, I wanted to show this slide from Freedom for All Americans, which is an LGBTQ community advocacy group looking at, non-discrimination protections in really across America. And you can see that the ones in the red or maroonish color are states that have non-discrimination protections, right? So about 21 of them. Unfortunately, the majority are still without LGBTQ non-discrimination protection. Wisconsin has a limited non-discriminatory protection in that it covers everything around sexual orientation, but not necessarily gender identity. So if you identify as trans or gender non-binary, then Wisconsin might not necessarily be a great place for you as far as, protections around public accommodation, housing, and healthcare. Utah, on the other hand, has both protections for SOGI, the sexual orientation, gender identity. However, there's also some limitations around certain statutes and coverage. Now, in 2022, so from 2017 actually to 2022, there have been more than 600 anti-LGBTQ bills that have been filed. And in 2022 alone, since the start of the year, about 238 were anti-LGBTQ. And it's really targeting the transgender and gender non-binary population. We obviously heard polarizing debates around gender affirming care in Texas, and also just the educational curriculum around sexual orientation, gender identity, and really just LGBTQ from kindergarten up to third grade, right, in Florida. So we know that this is an ongoing polarizing topic, and there's still a lot of oppressive bills that are targeting the population, but most especially the trans and gender non-binary. As far as healthcare disparities, there is already emerging robust data around healthcare disparities, and really targeting, the most vulnerable of the most vulnerable, which is really if you're an older adult, you belong to the Black and Indigenous people of color community, and you are also LGBTQ, that you are a triple threat, really by and large by society, and you are now prone to, frank discrimination. So, this slide really highlights that, individuals have experienced harassment, refusal of care by staff. There's also fear of persecution and discrimination, whether there's actual and blatant discrimination or prejudices. The fact that people are fearing going to facilities, going to assisted living, settings and nursing homes and so forth, it really is concerning. There's also reliance on informal caregivers. Now, this is not, this is somewhat of a unique situation. We call informal caregivers as chosen families, because a lot of the times the LGBTQ plus community have been disenfranchised from their families of origin. So what did they do? They try to find resources, social supports outside of their own next of kin. So they form networks around their friends or coworkers, and neighbors and other community supports. And so there's reliance on informal caregivers. But we also know that this is not always the case. Some people really don't have anybody at all, and they become unrepresented, in the community. There's definitely still ongoing gaps in knowledge and training. And there's been some assaults around inclusive LGBTQ questions and national surveys. And in fact, in 2017, that's the reason why you didn't really see Gallup Poll, sort of breaking through the population as a whole and really looking at SOGI, or sexual orientation, gender identity, because there were oppressive rollbacks around getting that information. The trans and gender non-binary individuals are openly made fun of because of their gender expression, and if they're not blessed with what we call passing or blending privilege in society, where they're living life in stealth and they're not necessarily called out for being trans, then they are, met with overt disapproval and discrimination from healthcare providers at large. There's also greater risk for disability, psychological distress, and there's a lot of known data around this, and even within the LGBTQ subcohorts, that there is in fact disparate proportions around physical and mental health outcomes compared to the cisgender heteronormative population. And one of the other things, because a lot of us practice primary care and practice health maintenance and preventative care. Unfortunately, because of the fear and the trauma that people have experienced over time, they've definitely rolled back on their privilege to be able to seek appropriate medical care because of this fear that they are going to be outed, they're going to be discriminated against, that they're not going to be attended to. And these are all really concerning data. Now, this is only a snapshot. There's definitely more. However, we don't have enough time to cover everything. But if this will not, caught us, and put us in our place, then I don't know what is, So this is really, there's a call to action for all of us to really take a stand and be strong advocates. Now, I just want to hone in on the transgender population because, of the LGBTQ plus cohort, this is the gender, non-binary, and the transgender population. I want to say there's definitely a lot of progress, but there still also is coming of age in a sense, because I think that the LGB in the acronym have already achieved significant milestones, and now the focus are in the TGNB or TGNC, transgender and gender nonconforming and non-binary. If you look at different domains around healthcare disparities, from HIV infection, homelessness, substance use disorder, you can see that across the board in pink, you can see here that the transgender population surpasses the risk rate of HIV, incarceration, homelessness, and alcohol or illicit drug abuse, substance use disorders. But what is even more staggering, and this was actually lifted from a 2015 National Transgender Discrimination Survey, that 41% of individuals have actually committed and attempted suicide compared to the general population. 2% compared to 41%, that is significant, and that is quite staggering, right? And, my heart breaks that the mental health of this sub-cohort in the community, is still subjected to ongoing prejudices and oppression. So what are some of the consequences of this? So we already touched on some of them. People end up returning back to the closet and hiding, not disclosing their SOGI. For the trans individuals who transition, they might detransition so that they can live their life in stealth and they can be invisible. We've talked about adverse physical and mental health outcomes that are still pervasive. And then, it doesn't encourage and doesn't entice the community to seek preventative and health maintenance screenings because of this perceived and actual fear of discrimination. And so what ends up happening is that there's this cyclical pattern that people then get persistently victimized as a result. And then they become invisible. And then again, the cycle kind of continues to unfold. And if people don't know what's going on with the community because they're not represented and they're not being talked about, then the powers that be might not invest in resources and in training and education around LGBTQ medicine, right? And this can also lead to propagation of policies that are not necessarily standardized and are favoring certain groups of people and certain cohorts of individuals. Now, looking at the palliative care, I was fortunate enough to work with this esteemed, experts in palliative care as well as LGBTQ medicine. We were able to publish a study back in 2020. This was a cross-sectional study, online survey looking at hospice and palliative care providers. So one would think that in palliative care, we are already inclusive, holistic, and comprehensive. But lo and behold, we are not immune to discrimination, or us practicing discrimination, or us being discriminated against. In fact, more than 2/3 reported that transgender patients were more likely to be discriminated against, and about close to 1/3 reported actual observation. And so the low number in terms of the actual report, probably also comes from the fact that if you don't report it at that point in time, you might lose that that cognitive fact. If you don't know what you're looking at and what you're facing, you might not realize that this is already outright discrimination. Or if you're the one who is implicitly committing the microaggressions and whatnot, you might not necessarily own up to it. So there's a lot of underreporting that's going on. The bottom line is that the providers in hospice and palliative care recognize, the overwhelming majority recognize, that LGBT patients are in fact a vulnerable population that are discriminated against, even in the most comprehensive, most holistic, most compassionate type of medical care. So what of the other types, what of the other specialties, right? It really does beg the question. Now, some of the anecdotal reports are really quite skin pinching, in my regard, and really heartbreaking. People are making fun, cracking jokes about transgender individuals and their surgeries. People, transgender and gender non-binary individuals are not even referred to as persons. They are called by a pronoun of it, as if that were an object, right? And when people are when with this community, the TGNC community has undergone surgery, it becomes like a focus of curiosity for people. You've got to see what surgeries they have. You've got to see what a vagina looks like, what a neo-phallus looks like, and so forth. And it becomes objectification of the individual rather than humanization of the transgender individual. So again, these are very disheartening comments that exist even in the specialty that we are in. So there's definitely, therefore, a call to action. Why am I showing you all of this not so positive data, right? All these prejudices that are happening, the disparities, because we have, in fact, an opportunity to act up. And you guys are taking the first step. The fact that you've invited me to give this presentation, the fact that you carved out time from your busy schedules, whether you're in administration, whether in your research or doing clinical work, to be here to listen to this talk. You guys are already taking a bold step and the first step, and you ought to really pat yourselves in the back. However, it's not enough to just get educated. We have to enact and enforce what we've learned so that we can really create impactful change. So our code of ethics is that we need to provide universal care no matter what. That's just the bottom line, right? And this can also hold true for individuals who don't have insurance, who have substance use, who are HIV positive patients, who work in commercial sex work. That it's not our place to judge lifestyle or life choices and so forth. Our role, even if we might disagree with our spiritual, religious, and beliefs, are as long as we're not encroaching on morality and dignity and individuals, I think that that we can continue to provide care even if we can respectfully agree to disagree, right? We've also seen multiple organizations, from physician associates to geriatricians, psychiatrists to nurses, really medical professionals, all in one, are bonding all together because they've all realized that there's a need. And similar to what happened in 2020 when George Floyd was killed, around racial disparities and ethnic disparities, LGBTQ is not far out from that. So we're all jumping in on this. I'm glad that we're putting the spotlight. This has been an ongoing issue for time immemorial. However, I take comfort in the fact that we are focusing on this. Now, it's not all doom and gloom. In fact, in April of 2021, when President Biden took his addressed the joint session, he really called out the LGBTQ as a whole, but especially the transgender and gender non-binary individuals that his administration has their backs. And then we've also, in March of 2021, there was the passing of the LGBTQ rights bill in the House, right, in Congress, and now it's in the Senate and waiting approval. And I could not overemphasize the LGBTQ rights bill or the Equality Act, because if this gets enforced, then there's going to be federal protections across all domains, from public accommodations to housing, employment, education, healthcare, and so forth. And your people are going to be protected. We've also heard that Rachel Levine made history as the first openly transgender individual, a woman of trans experience, who was officially confirmed by Senate and an assistant to the health secretary, right? I'm really proud of Rachel Levine. She's also a Sinai trained pediatrician and was a surgeon general in the state of Pennsylvania, and really took office now with the Biden administration. Now, in the nursing home setting, we have the Federal Nursing Home Reform Act. And what if this act is properly enforced, then there's going to be a cultural shift, because people are going to change attitudes around LGBTQ. Everyone's going to have cultural sensitivity training, and there's going to be expanded research and protected policies around the care for this individual. So this definitely is out there and in the nursing homes that we see, and in fact we even have a healthcare bill of rights that's adopted from just the Human Bill of Rights for any individual, that really calls into play the fact that all professionals should really be treating individuals regardless of their sexual orientation or gender identity. I also just wanted to put a little bit of a statement here that there's been some progress as well in terms of senior housing for LGBTQ adults. We have a couple. One is the Stonewall House in Brooklyn, which is 50% LGBT, and the other 50% is non-LGBT. And this really will allow for our aging LGBTQ adults to have a safe space. Because let's face it, the reality is that if they just go to your run-of-the-mill assisted living or independent living facility, that if that facility is not in the know about LGBTQ, then they're going to be subject to discrimination. And there's also one with Crotona Senior Residences up in the Bronx. And this is really in partnership with SAGE, which is the Services and Advocacy for GLBT Elders, which is really the think tank and quite the advocacy group for our older LGBTQ adults. The downside, though, in this is that this is great because this is a safe space for our older adults. My worry with this is that it becomes a very siloed approach, as if we want to distinguish LGBT from non-LGBT. And and to be fair, I mean that these two residents are really trying to accommodate both and not just distinguish one over the other. But I wish and I pray that this is America as a whole will catch up and will really include and blend individuals from all walks of life. We've also heard this individual from Maine who was discriminated against because of her trans identity, and she was denied admission to an assisted living facility. Thankfully, Maine, being a progressive state, was able to pick up on this quickly and drew up a bill around changes in just the adult care network. And finally, in June of this year, President Biden, during the Pride event, again, wanted to make sure that there is executive action after R v. Wade was struck down, that that the next group that's going to be targeted will be LGBTQ. Now let's take a breather, because this is a lot. I want to segue into the second part of the talk, which is really for us to develop a cultural lens of understanding, because I don't think that we can go from point A to point B and answer the call to action if we don't go back to the basics. So let's review some terminology. So sexual orientation, gender identity, how do they differ? So on the left side is a cartoon looking at the gender unicorn. So gender identity is your internal sense of being. Gender expression is your external manifestation of how you identify, and it may or may not be congruent with how you identify internally. And then you also have this concept called sex assigned at birth. And the reason for this is to bring out in the open transgender identified individuals. And then the last concept is that of sexual orientation, which is your physical, relational, sexual attraction, behavioral attraction, or affection for another individual. Now, to the right is a Venn diagram intersecting all of these domains, that they are all interconnected. But the heart of it is that what really drives is the authentic self of the individual. And if we look at the authentic self of the individual, however they identify from their gender identity or sexual orientation, however they manifest themselves, we have to look at the individual as a whole, and that there is an intersectionality of different identifiers. Now, you might be wondering, what is this term called cisgender? So transgender is a misalignment between the gender assigned at birth or and your gender identity. So your sex or gender assigned at birth is biological. It's the biological definition tied to your anatomy, your genitalia, your chromosomes, and so forth. Whereas gender identity is much more of a psychosocial construct, right? Because we know that you're beyond your anatomical parts. And when these two are misaligned, you're called trans. However, the counterpart of this is cisgender. So an individual who is assigned male at birth and who identifies as a male is called a cisgender male, and similarly for women as well. Thankfully, SOGI is now included in your U.S. Census Bureau. In fact, in July of 2021, the Household Pulse Survey included SOGI. So this is great. This is a step in the right direction because we are making individuals in this community much more visible. You guys are probably also familiar that in 2017, this was featured in the New York Times, looking at SOGI disclosure. So this equality study was done in the greater Baltimore area, and they did a combined in-person and online survey, and they paired, they looked at providers and also respondents, and they were just curious to hear whether or not disclosure of your sexual orientation and gender identity is a big issue. Are people really comfortable or not, right? So what they found out was only 10% was in fact refused to reveal their SOGI information. So the overwhelming 90% felt comfortable disclosing their SOGI information. And I kid you not, the majority of the individuals who actually shared SOGI were the cisgender and heterosexual individuals, right? And but this is the thing that was really alarming to me. More than 2/3 of providers thought that SOGI was going to be refused by patients to ask, and so this becomes a debate now because people, when they come into the emergency room or when they see their clinicians, the clinicians might not necessarily think of SOGI as a relevant topic, right? And they would either gloss over that, or they don't feel comfortable, asking that question. But this is what we're saying, that if you're not comfortable, then how will we be able to represent this community? So the way to mitigate this is we need to implement a standardized collection of SOGI data. And in a correlative study looking at the transgender population, same group, in Greater Baltimore area, transgender identified individuals actually were overwhelmingly willing to share their SOGI information. But if they had to choose between the SO and the G, they would rather have the G expressed, but nonetheless they're willing to share both. And overwhelmingly these individuals are comfortable sharing their SOGI because they also know that types of care are nuanced in this population. So how can we curb this in our own practice settings? Just include it in your demographic data. Lump it in with some of your demographic data around language, racial group, ethnicity, gender identity, all of those things. If you use Epic, here at Sinai, we use Epic, so we were able to include this SOGI in the electronic medical record. And so now we have this in all our inpatients and outpatient setting. But mind you, this took like years in the making, but we finally were able to get it up and running. So this is a good example, right? So if you have a patient before you and you let the person answer the question in front of you, you ask them, what is your gender identity, the person might check male and also might check transgender male. And then when you ask a question, what was your sex assigned at birth? And then they say female, then you know that this is a transgender individual. And then of course you ask the pronouns, right? He, him, his, because not every transgender individual will identify as he, him, or she, hers. Some actually also identify as gender non-binary, so or queer, right? So transgender and queer or non-binary. So they don't identify as a purely he or her, and they use pronouns like they, them, z, zir. So yeah, so it's for some of us, this might get confusing, but as we catch up in our education, I think that we will be able to understand the difference, the distinction between the two. And thankfully, so again, looking at some of the gaps even in hospice and palliative care. So there was this collaborative group around palliative care organizations really wanting to create a registry around programmatic and development and patient level type of centered care. But what they neglected to include is SOGI. So, a few of us really was able to see that there was a gap in this. And again, this is an inadvertent lapse in judgment wherein SOGI was not included. And we had to really fight for it and advocate for it. Now I'm going to segue. So after you've learned the SOGI information of your patients, and if you have a patient or a client who's identified as LGBTQ, let's take a dive deeper. Let's look at some of the stressors that this person have experienced, right? So this is the Elan Meyer minority stress model. And I'm going to guide you through this because it's a little busy. So let's start on the left side. So the left side shows that as an individual, as a regular human being, you have general stressors in the community. But as a minority, based on your SOGI, you even have unique stressors within yourself. So you combine general stressors around just living your day-to-day, your employment, your education, your family, whatnot. And then if you belong to a minority population like LGBTQ, you have to struggle with your own internalized homophobia, transphobia. You have to struggle with externalized biases and prejudices that are targeted against you. If you're a victim of abuse and trauma, you have to deal with that. So just imagine that the combination of general stressors on top of your unique minority stressors can lead to an aggregate effect that will ultimately result in significant mental and physical health outcomes, as seen in this box right here, right? Thankfully, because we're all individuals that have adapted over time and we can access resources, there is also the concept of resilience and crisis competence and robustness, and that's through coping and the social support network. Now, I wanted to illustrate on the next slide that the LGBTQ population has been subjected to significant negative and positive milestones, right? So speaking of minority stressors, just imagine, back in the 50s, gay people were considered perverts. They were featured in a magazine called Look magazine, and the title was The Sad Life of Being Gay, being homosexual, and that LGBT was considered a sociopathic personality disturbance, at that point. Thankfully, in 1969, a group of trans and LGBT, gay and lesbian and bisexual individuals all gathered around, and they said enough is enough, and they were able to fight against the oppression that was happening. And as you can see over the years, our Medical Psychiatric Association, American Psychological Association, they all caught up, and they felt that this is not a disease. It's not an ailment that needs to be fixed, right? So things like conversion therapy, all of those, electroshock therapy, just imagine people were subjected to electroshock therapy. These were all now banned and discontinued for the most part, right? Although I will say that unfortunately there's still people who are in states that are unfortunately using these types of therapies. And we've also seen that, particularly of late in the Obama administration, there was, superb progress with the striking down of DOMA, federal recognition of same-sex marriage and employment non-discrimination back in 2020, when thankfully the judicial system, the highest court, were able to side with the plaintiff around discrimination for being LGBTQ in your employment spaces. Now, if we've learned about the different milestones, I hope that the next step for us is to eliminate our biases, because we all have one or two, right? We all are victims to our own implicit biases. And the problem sometimes is we focus on, so knowing the basics about minority stressors and the milestones, we tend to think that, LGBTQ is a doomed, population because of all of these upheavals. Let's not forget that there's also positive strides and progress in this. And so our goal is not to pass any judgment, right? And I think that we can certainly eliminate our biases, though very hard. It's not for us to completely disengage or disentangle ourselves, because we're only humans, we're subject to biases. But our goal is to make sure that we recognize these biases as potentially troublesome and to mitigate them as best as we can. And the best way for you, as an affirming tip, is to engage in unconscious bias training. And by doing unconscious bias training and eliminating our biases, we can now come full circle that individuals have their own lived experiences. And if we listen to their story, because, these lived experiences are governed by the fact that there is, significant transition points over time as impacted by society called the life course theory. There's also a complementary theory that as individuals in the LGBTQ plus community evolve over time, that they're able to rely on, their experiences to help them adapt and to help them achieve a lot of the goals. So, even though we're not experts in the care for LGBTQ individuals, we can partner with them and we can collaborate with them by asking a little bit more about their lived experiences. I'm not going to go into too much detail with this because I kind of touched on this in the minority stress model, but I just wanted to say that the resiliency of individuals could not be overemphasized. And how are they becoming resilient, whether it's individual or community-based? They draw a lot from internal and external resources. Internal resources such as spirituality, volunteerism, self-acceptance, and also external resources by developing interpersonal relationships, by developing, connecting with advocacy groups so that they're really fighting for their right to take a seat at the table. The one thing that I also wanted to just highlight on here is this concept of crisis competence. This was actually born out of the HIV/AIDS epidemic back in the 80s, where gay men were unfortunately the victims of HIV/AIDS and had died. And it was their partners, their chosen families, their neighbors, both gay, lesbian, bisexual, transgender individuals who rallied around them. And people then developed this ability, this adaptability to be able to withstand any type of stressors and to adapt to it by tackling and focusing on the resources that are available. And then if we sum everything up, we want to focus on intersectionality, right? Because I think if we looked at the milestones, the minority stressors, their SOGI, you're looking at a person. If you look if you look at yourself in a mirror, you can see that you are made up of so many parts. Your face has so many parts, and these are all interconnected parts. And it's the same thing when you're looking at an individual. So when you look at your client or your patient, consider that as a mirror, not necessarily a mirror of you of who your SOGI is, because your SOGIs might be different from them, but just looking at them from a humanistic and compassionate standpoint, that these are people that you are taking care of. So intersectionality is the intersectional identities is the overlap, the confluence of all of these identifiers that we have that really make us who we are, right? So I'm going to put myself as a case study because I think that I can have a better impact if people know who I am as a human being, as an individual. So I have multiple intersectional identities. Some people know, some people might not know. I am proud of my intersectional identities. I am a woman of trans experience that identify as heterosexual. I'm also an immigrant, and in 2015 was blessed to become a naturalized American citizen. I do come from a developing country in the Philippines where I trained, so I have my own upheavals with that as well, having to fight for my right to, to practice medicine here in the States. I am also Catholic. I practice my own spirituality, and I have, and what I wanted to kind of highlight here is that both on the left side and on the right side are the challenges that I faced, whether it's finances, whether it's taking exams, or you know, re- you know, recognizing my authentic self, and also just the positive ends of this as well. That I was able to be here because of support that I've gathered from people, from within my circle, from my own family, and my network of friends and colleagues and whatnot. And finally, to sum it all up, I think that we can move forward with answering the call to action by remembering all of those guiding principles that I've shared with you, by taking them to heart and really practicing this intentional form of cultural humility, right? Because even though we are the authors of our own lives, we cannot write the narratives of the people in front of us. And we need to be able to, meet them where they are at. And practicing cultural humility means that you practice open-mindedness. You don't have pride. You are self-aware and also self-critical about yourself, and being thoughtful about how you're interacting with individuals, and how you're thoughtfully crafting, a plan of care for them if you're a clinician. And I think that if you practice cultural humility, then this goes a long way as far as, rising to that call, for action. Now, how do we operationalize cultural humility? Because we can all have an educational session about this, and it's great to remember. However, thinking about this and memorizing is not going to cut the mustard, right? We have to really take action. So one, this is the easiest, just have visible signs of indicators that you are LGBT inclusive and affirming. At Sinai, we have a big billboard, healthcare bill of rights. When you walk into the lobby, that's the first thing that you will see on the left-hand side, plastered on the wall. If you have a rainbow flag attached to your ID badges, if you have pins, if you have your pronouns attached to your names, these are really helpful signs that you are welcoming in your clinics, or work offices, administrative office spaces. If you have magazines and that paraphernalia that is LGBTQ inclusive, it will really help individuals know that you are that you care for people and you think of them. I want to draw your attention to the last bullet, which is called the dignity question. So we talked about listening to the story and how the lived experiences and intersectional identities are all intertwined, and we want to be able to meet people where they're at. If we practice the dignity question, which is a Chochinov created question that really applies not just to LGBTQ individuals, but really a lot of individuals as a whole, then I think that we can really break the ice. So the question is, what do I need to know about you as a person to give you the best care possible? I mean, you can't be more concrete than that, and that really will allow the individual to hopefully disclose a little bit of themselves if they're comfortable. And if they're not, don't fret. There's always a second follow-up. There's always another visit, hopefully, with this individual staying with you. I also wanted to share with you that there are resources out there in the electronic world, Safe Zone Project, SAGE, support groups, and other resources that you can all just Google. It really is within your fingertips. But I think one of the most important things, and I could not harp this enough, and this is in conjunction with CIPC's, one of the tenets of, the tenets of the practice itself as a whole, as an organization, is and as a program, is the fact that we want to be as interprofessional as we can. We want to lean on individuals who have various expertise, whether they're social workers, they're psychologists, they're theologians or chaplains, creative arts therapists, and so forth. We cannot do this alone. It takes a village. for us to be able to help, clients and our patients. And again, if you drew back to the intersectional identities and the overlap, it goes without saying that our interprofessional team, and this is the reason why we're having these conversations in the first place, is, could not be overemphasized. I am just going to check in. So maybe I'll just do a couple of more slides because I want to give time for questions. But I wanted to do another case study. So let's say you're in an office space, you're seeing a patient, and you have just attended this session. You're excited to use your skills. You want to engage in a physical exam and a history taking. Obviously, you want to get to know the patient. So there's some basic practice skills that you can use, right? Introduction is key. If you introduce yourself with your name and your pronouns, it will go a long way. The other thing is that if you're going to ask people about their SOGI, it can be quite, it's a very sensitive topic, and some people might not necessarily feel comfortable disclosing their SOGI, particularly in the traditionalists and also the baby boomers, right? They might not necessarily be comfortable, with SOGI disclosure. So if you use some kind of a script to be able to guide your conversations, it will be really helpful. So something like, you preface your conversation with something like to the effect of, I want to provide holistic care to everyone, including the LGBTQ population. Is it okay if I ask you about your sexual orientation and gender identity, right? For the most part, people are comfortable sharing that information. And if you come to a halt where some individuals are like, you're crossing the line here, you take a pause, you give them an opt-out, because some people, it might take a while for them to even engage and disclose this type of information. And also come from a place of curiosity and exploration. Like, tell me a little bit more about why this question is very triggering for you. And we can, and you can say, we can table this question for now, and then we can readdress it again at some other time. Again, if you answer, like, if you use the dignity question, that in of itself is an icebreaker, right? What do I need to know about you as a person to give you the best care possible? And hopefully it would be open-ended enough of a question that they will disclose their SOGI. It's not always a guarantee, but again, sometimes people need to build trust over time. I think it's really important for you to ask about their social supports because of the chosen family support, right? Who are you living with? What's your current living situation? Who are your supports? And try to be as neutral in your language and not judgmental, because there's some judgmental questions that inadvertently might come off that way. Like, like something along the lines of, okay, are you married? And if you're married, who's your husband? If you have a female identifying individual in front of you. So there's already this implicit bias that if you're female identifying, you must be cisgender and heterosexual, and so therefore your spouse is a male, right? So if we put that, at the table and just, be very neutral in our language, do you have a partner? May I know, the sexual orientation, gender identity of your partner if you're comfortable sharing, something along that line. Now, when you're doing a physical exam, I just want to hone in on the transgender and gender non-binary individuals a little bit, just because, these are the individuals that may have undergone affirming surgeries. And if they have, it's not okay for you to just assume labels of the body parts. You want to partner with them and have them take the lead. So you might say something like, how do you want to label body parts and so forth? And if you're comfortable, is it okay if I, do a physical exam on this particular section? And try to really explain, why is this relevant? If a person is coming in with a chest cold, do you really have to do like a genitalia exam at that point, right? However, it's also important to do a full anatomic inventory, right? If you're doing a wellness check and they still have their original parts or their birth parts, then you have to ask permission and explain to them that this is important because this is part of health maintenance screening. Sexual health information is very delicate. Again, you want to preface, have a script handy, and just treat it as a normal part of the discussion. Part of providing holistic care is eliciting sexual health information. Are you comfortable sharing that with me? And then if you commit a mistake, let's say you misgender an individual, apologize, don't dwell on it, and then move on to the next. And also just be intentional to not commit the same mistake. I think one of the the pitfalls in the relation as people are becoming much more woke in taking care of transgender and gender non-binary is that they kind of feel like, oh, I might say the wrong thing, and they end up walking on eggshells. And that's not what we want, right? What we want is normalization of this. So if you don't know, just say, you know, I don't know what your pronouns are. Could you tell me your name and your pronouns, you know? And in that way, it will be helpful. Finally, I wanted to talk about goals of care, because for those of us here who are practicing clinicians and engaging in goals of care discussions, it's really important for us to hone in on this. And I've already spoken to you about some of the tools, and the tools are not necessarily unique to LGBTQ palliative care. But I think what is probably the one thing that I want to focus on is the biopsychosocial, cultural, and spiritual framework. And again, we use this a lot in palliative care for non-LGBTQ patients anyways. But I think what I'll probably emphasize on this is just a bit more nuanced and just a little bit more time, you know, really dissecting and understanding this framework. And again, I could not overemphasize that the interprofessional approach is really helpful. So what are our take-home points, you know, for this session? Number one, nuanced approach. Not LGBTQ fits a box. No one size fits all. No one box fits all, and we need to be nuanced in our approach. Again, if you keep in mind the multiple minority stressors, the intersectionality of individuals and the lived experiences, I think you'll be in a good place. You want to engage in cultural humility training. This is the first step. Now it's carrying out, right? We want to do intentional cultural shift. So how do you do that? By changing language, changing policies, including SOGI in your EMR. And we want to be able to do more research and expand the policies protecting the rights of the LGBTQ plus community, because we can do a lot more. I just included some of these resources, and you're more than welcome to access this slide. To Bridget and you know, you feel free to you know, to include this in the repository. Finally, I want to end with a quotable quote from James Baldwin, who's a leading activist in LGBTQ rights. And what he said is really thought-provoking, and I hope that this sums up everything, you know, that I've talked about today. Not everything that is faced can be changed, so we know this, right? And sometimes it takes a while, but nothing can be changed until it is faced. So until we put LGBTQ on the map, we will never progress. So with that, I really thank everyone for allowing me to speak today, and I'm more than happy to answer your questions. Thank you.
Thank you so much, Noelle. We only have a few minutes left, but this was so good. Does anybody have a question? I know Alana was curious about, had a question back when you're presenting the transgender, and she was what it would look like if there was a non-binary or genderqueer question. Alana, do you want to bring that up?
Oh, sure. I was just, when you were presenting the data from the national survey with the percentages of LGBT folks, I was surprised that it was only 7%. And I was curious what that, you know, what that percentage would look like if non-binary or genderqueer was included as an option.
Yeah. So
do you know if like Conquer or anything is doing any kind of national survey that's has a more expansive definition?
Great question, Ilana. I can tell you right now. So that did not really include the gender non-binary, and people were probably included there, but it wasn't like called out right off the bat. The good thing is that the same surveyors are doing a recent survey as we speak. At 2022. The data that's being collected is 2022 to 2023. I actually just took part. I answered that survey not too long ago. For some reason, I was able to get the link. I'm sorry, I don't have the link, but I'm pretty sure if you Google it, it should come up, because it's like, you know, being advertised. So now they are including the gender non-binary, because, you know, the sad reality is that even though the trans community is at least slowly inching up to speed with the LG and B, the gender non-binary is still not there, not even close. So I think that we have room to grow, and I think people are realizing that now. That is an important aspect. So great question.
Well, everybody is loving the presentation, and it was very, very eye-opening for me. Some of the data were so sad. Yeah, and I can't thank you enough. And I hope everybody remembers their cultural training and asking the dignity question. Tom, did you want to say anything? Or?
No, just thank you so much. And for those of you who are online and may not know, we have a Center for Sexual and Gender Minority Health within the School of Nursing. It's the first in nursing in the country. We partner with the Department of Psychiatry. So if anybody has questions to follow up on this, please contact me or Lauren Porsche or anybody in the Center for Sexual and Gender Minority Health. And thank you so much, Noelle, for your great talk. It was a wonderful foundation, I think, for people working in any area, and particularly in palliative care. So thank you so much.
Thank you so much again, Tonda, Pat, Bridget, Kadra, for the invitation, extending it to me. And I had a couple of folks who I actually know of. Ronit Elk was one of them. I think she left. And Mike Nalepa was my fellow back in the day. So he's now attending up in Colombia. So this is great.
Thank you. I have to go to another meeting. So thanks, everyone.
Thank you. Bye-bye.